All right, in this audio lecture, we're going to be covering acute respiratory distress syndrome. So acute respiratory distress syndrome is really an indicator of failing lungs, right? So now your lungs aren't able to perform their job, which is to exchange gases. And so we see an inadequate level of oxygenation in our blood. Now, this condition can be the result of several different conditions. We see that shock, which is going to affect blood flow, is going to be affecting this. And so we talked about shock previously in the cardiovascular chapter. However, we only talked about it in the effects of tissue perfusion outside of the pulmonary circulation. But anytime that you reduce the pressure gradient, you are reducing that driving force for blood flow. Burns really provide a nice source, and so you could actually go into hypovolemic shock when you get a burn because you get this massive dehydration from your circulatory system. And so we can see burns resulting in shock. If you aspirate something, so if we'll say gastric acid, if you aspirate gastric acid, okay, or vomit or something like that, that ends up causing an inflammatory response inside of our lungs, increased mucus production, bronchoconstriction, and this could be this could reduce alveolar gas exchange, right? Smoke inhalation is going to do the same thing, and that's inhaling an irritant. And so this irritant is really going to prevent proper function of the respiratory structures. So this acute hypoxia that is resulting from the acute respiratory distress syndrome can really originate from two sources. One is systemic and one is pulmonary. And so the systemic inflammatory responses are going to be induced by drug overdoses. And so they are causing systemic vasodilation, reducing that driving force, reducing the pressure gradients. Okay. Cardiopulmonary bypass is skipping the lungs real quick, and then we're pretty much going from the pulmonary trunk to an artificial respirator and skipping the lungs in that process. Right? Then we have a transfusion reaction. The transfusion reaction will create a mismatch in blood, and so we actually start destroying some red blood cells. And this decreases our ability to transport oxygen. We have pulmonary inflammatory responses as well, right? So the same one that we saw here, drug overdose, okay? Toxic gas inhalation, right, is going to really prevent the lungs from doing their job, and it might lead to bronchoconstriction. RSV infection. So this infection is going to create an inflammatory response, and anytime we have an inflammatory response in the lungs, we really close up those airways because the purpose is to reduce the ability of that infection to spread to other parts of the body. We see multiple other aspects in this area, and so pneumonia, gastric acid aspiration, and so this is talking about inhaling some stomach acid. Okay, and the stomach acid, when it touches our respiratory surfaces, they close up. They don't like it, right? So you get this massive bronchoconstriction and massive mucus production, right? And so we see that near drowning. So this is actually putting fluid into our respiratory cavities. And so if that goes all the way down to the alveoli, that is a concern because now we can't efficiently exchange gases between the air and the circulation. And then fat embolisms. So if these fat deposits in plaques end up becoming dislodged and they travel through the circulatory system, they can block the capillary. And if we block capillaries in the lungs, we are blocking pulmonary gas exchange. So we have several chronic causes, so causes that are underlying diseases that cause the acute respiratory distress syndrome. One would be emphysema. Okay. So emphysema reduces your ability to exchange gases. It reduces your ability to actually deflate the gases. And so we actually get impaired lung movement because of that emphysema. Chronic bronchitis means that we just have this chronic inflammatory event resulting in chronic inflammation of our bronchi and our bronchioles. Asthma really has the same effect, except it's really on short basis. Okay. Alcoholism can cause this acute respiratory distress syndrome. So alcohol decreases blood pressure and vasodilates, and so we oftentimes see that it can decrease blood pressure to such an extent that that perfusion gradient for driving blood flow is absent, or it can decrease too much. We see that age is a factor. So just because getting old is not the best thing, right? And so things start working inefficiently. So your age starts to show its years on your lung function, right? On its ability to exchange those gases. Mechanical ventilation. If you're chronically on mechanical ventilators, we can see an impairment of the lungs as well from multiple causes. So we can see bacterial infections, we can see irritation of the respiratory linings resulting in bronchoconstriction and excessive mucus production. Okay. So how is this going to manifest itself? Well, we're going to have labored breathing, and we're going to take shallow breaths. So rales and bronchi are going to be present, so those lung crackles, and then the abnormal sounds are going to be there. For a cough, we're going to expect a productive cough. Okay, so it's going to be frothy sputum in this case. And the manifestations associated with hypoxia are going to include cyanosis, so the bluish tint to your skin, especially of the mouth and the lips. We see tachycardia. Anytime you have a decreased oxygen capacity of your blood, we're going to be increasing heart rate to try to compensate for this. Anxiety, because hypoxia triggers anxiety. Confusion, lethargy. So the last three are all due to neural effects, and then we see the first due to the oxygenation of the blood. Yeah. Some other manifestations, we can see fever, hypotension, because shock is a common cause of this respiratory distress syndrome, and restlessness would be another result of neurological effects. All right. So the first step to acute respiratory syndrome is going to be lung injury, right? So you have this injury either to the lung or to the, you're generating the systemic inflammatory response. And so this results in really injury to the pulmonary endothelium. We get a response from the endothelium, and that it is hyperproducing exudate, right? So the exudate is going to be secretions like mucus, fluid accumulation. And the third step, so here's the fluid exudate accumulation. Notice how we have multiple aspects of it. We have fibrin and interstitial cells preventing expansion of the alveoli, protein, blood, fluid inside of the alveoli themselves. Of course, mucus would be included in this, but really the result is the lung is becoming non-compliant. So the fluid inside the alveoli really resists expansion. The fluid inside the interstitial space and the fibrin really reduce how much we can expand our alveoli. So the result is that we start decreasing gas exchange in this event. Ultimately, we cause damage to the type 2 alveolar cells. And so the type 2 alveolar cells produce surfactants, and surfactants' role in the lung function is to keep it open, right? To reduce the surface tension that is associated with water. So if we reduce the surfactant, we can actually get this lung collapse as a result of this decrease in surfactants. So the consequences on alveolar function can include hyaline tissue formation. So recall that we don't have hyaline tissue normally in our alveoli. It is simple squamous epithelial cells that promote the rapid exchange of the gases. This hyaline tissue that is there really acts as a barrier to efficient gas exchange. Because we have reduced our gas exchange, we start to suffer from respiratory acidosis. So I'm going to expand on this more in chapter 6. However, you should be able to understand that we get an acidotic condition, so we have a pH less than 7.35 that is of pulmonary origin, right? So this might indicate CO2 accumulation, or it actually does indicate that. But so be thinking about that in that perspective, right? So why you would see acidosis, because carbon dioxide concentrations are increasing. Right? So in the end, you end up getting irreversible lung damage, and so now your lungs can't actually recover from this. We can't exchange more gases. We can't come back from where we were. If our lungs damaged and we start to fail in pulmonary failure, we start to see cardiac failure as a result, because now the myocardium isn't getting enough oxygen. And remember that the heart doesn't do well in the absence of oxygen. The end result really is multi-organ failure. So once you damage the lungs, then the heart starts to fail, and then if you can't perfuse the organs, With an adequate amount of oxygen, we start to see other organs fail as well. And so we're going to see symptoms from these other organs. Okay. And we'll talk about treatments more at the end of the lecture. Right. So we have other manifestations, and the other manifestations are all going to revolve around the manifestations associated with the other organ failure. Okay. So some common results from acute respiratory distress syndrome: respiratory failure, obviously. Acidosis is a really strong indicator that we have this acute respiratory distress syndrome. Pulmonary fibrosis, so we get replacement with scar tissue compared to the normal tissue is there. And then if we start to replace these areas with tissue that's not supposed to be there, we might end up getting a pneumothorax or air in the pleural cavity. Some other results of this: since we can't mobilize those fluids too well inside of our pulmonary cavity, we can see we are in increased incidence of bacterial infections, okay? Decreased lung function as a result of the impaired gas exchange, and then from the other manifestations like pneumothorax, we might have a hard time ventilating that lung specifically. Now, renal failure is going to be a disorder after the lung disease has really started to set in, and we start to see some cardiovascular failure. Renal failure is going to be the next one to go. So this one the brain flow is maintained, so we'd like to hold on to that as long as possible. The kidneys are directly affected by this decrease in cardiovascular function, which ultimately depends on the lung function for its activity. Then we have muscle wasting because we're not delivering enough oxygen to our tissues, so we start to break down things to undergo anaerobic catabolism, and then we suffer from some neurological problems such as memory loss. How are you going to diagnose ARDS? History and physical examination, presence of any of the manifestations are going to allow you to kind of deduce out these other diagnostic tests here. So arterial blood gases might indicate elevated carbon dioxide levels and reduced oxygen levels. A chest x-ray is going to show a lot of congestion inside the chest x-ray. And then CBC would indicate, as long as it's not due to a lysis of red blood cells, we're going to expect an increase in red blood cells, which is called polycythemia. Okay. So how are we going to treat ARDS? Really, we're going to try to maintain oxygen therapy, right? So by providing extra oxygen to increase the concentration gradient, to increase diffusion of oxygen into the blood. Endotracheal tube intubation, if our lungs actually, if we've lost a neural connection and we can't ventilate our lungs, remember that we control them in our brainstem through these central patterns, right? So we don't actually have control of it. These are just controlled by conditions in our body, right? If this cause is due to bronchoconstriction, these bronchodilators will help open it up and reduce that inflammation event really that is occurring in there. So some other treatments can include antibiotics if a bacterial infection is present. Corticosteroids are going to have the same kind of activity as bronchodilator is, but it's going to more directly target the inflammatory event happening. Embolytic precautions. So now one of the issues with shock and decreased blood flow is formation of blood clots in the circulation. So these formation of blood clots, you would really want to reduce their capacity to travel to other locations and cause other damage. We have cardiac support, in that we want to so we might deliver CPR, right? So we want to make sure that blood is moving and exchanging some gases with the cardiac tissue. That is the whole point of CPR, cardiopulmonary resuscitation, is we create a pressure inside the thoracic cavity, move the blood, and then we ventilate the lungs to exchange that gas. Okay. So this is the end of the audio lecture on acute respiratory distress syndrome. Until next time.